welcome to Texas Bariatric Solutions. This is our webinar. My name is Dr. Drew Howard. I am glad that you have taken the opportunity to look at our website. I tell you about myself. I am board certified by the American Board of Surgery. I did my fellowship in bariatric surgery specifically at the University of Florida. Prior to that, I did my general surgery training in Alabama. My medical school was done at San Antonio at the University of Texas, and did my undergraduate at Texas A&M University. We are a comprehensive bariatric program. We are with you here from start to finish. Today I want to talk to you about just kind of first the problem of obesity and where we are in our nation. Second, some of the treatments for this severe obesity. And then what outcomes you can expect specifically for surgical treatment of obesity. And numbers I give you will be facts. They will be heavily researched numbers and what you can expect. And then if this is something you're interested in, what are the next steps? What would we expect, and what would be the steps to get you to surgery, and after that. We're with you here the whole every step of the way, and we look forward to meeting with you. So first, looking at definition of obesity. We define obesity as BMI, or body mass index. This is just a comparison of weight versus height. This gives us a number, and based on that number, you're either in the normal weight category of 19 to 25, overweight 26 to 29, obese 30 to 40, greater than 40 is morbidly obese, and greater than 50 is super morbid obesity. Here's a little chart that you can see. This will let you look and see your height versus your weight, and kind of see where you fall. Anybody who falls in this red area of 35 or greater BMI qualifies for surgery. The other areas, we know diet and exercise have a good chance of getting you into a healthier category. You can also go to my website and look this up as well. So obesity is an epidemic. We know that 1 out of 20 Americans is currently morbidly obese. That's a BMI greater than 40. Over 78 million Americans is obese currently, and 15 million are morbidly obese. By 2015, it's thought that 2.3 billion people will be overweight or obese, and then more than 700 million will be obese worldwide. What we can see is a trend that has happened over the last many decades in this country. What you can see in the early 1990s is the percentage of people who were considered obese, BMI greater than 30, is around 10 to 14% in most states, some even less than that. 2000, we're up to about 20 to 24% in most of the South, and about 15 to 19% of other states that claim that are people with BMIs greater than 30. And then you can see 2010 data that through most of the South, it's greater than 30% of the state has a BMI greater than 30. Morbid obesity is a disease. It's been called a disease by all of these organizations. The reason that is because what you can see is it causes all these other disease and disease processes, whether it's arthritis or reflux or high blood pressure or cholesterol problems, gallbladder problems, liver disease is becoming a big problem, or diabetes and heart disease, all problems. Obesity is actually the second most preventable cause of death in the United States right now. Second only to smoking. Tobacco still kills more people every year than obesity, but those numbers are trending in obvious different directions, with obesity going up in the number of deaths per year and tobacco going down. And then healthcare dollars are actually equal now on how much is spent fighting each disease. Obesity actually kills more people than breast cancer and colon cancer combined in a single year. The impact of obesity. So obesity impacts all of these areas of our lives. First, it increases disability and the number of people who need to go on disability. Increases medical care costs. Increases mortality or the risk of dying in a single year. Decreases people's quality of life and increases all these other medical problems that are associated with it. What you can see on this graph is on the over here on the left side of the screen, you see that your chances, if you are obese, BMI greater than 30, of getting diabetes, gallbladder, high blood pressure, dyslipidemia or high cholesterol, insulin issues, um, sleep apnea problems, or just trouble breathing, are more than 3 times compared to somebody who is normal weight. You can see in the middle it's 2 to 3 times increased risk for heart disease and arthritis and gout. And then on the right, 1 to 2 times increased risk of cancer, specifically breast cancer, endometrial cancer, and colon cancer. And in fact, research has recently shown that if you get cancer and you are morbidly obese, you are 2 times more likely to die than somebody who is normal weight and has that same cancer at the same stage. You can see here, once again, diabetes, a very big concern. Once your BMI goes over 35, your chances of getting diabetes just seem to skyrocket. And here's your risk of death. So you can see the men and the women's graph separately. You can see that as your BMI goes up, so does your chance of having an event that will end your life. Now, what causes obesity? Well, it's kind of a three-headed monster. First, there's the environment we live in. You can see in the 50s when McDonald's and Burger King first started having hamburgers, they were a little smaller than they are today. In fact, these are what we now seem to call Happy Meals, and now you can get as many hamburgers as you want, and you can supersize your fries as large as you want to. You can see as well Cokes, when they first came out, 6.5 fluid ounces. Now you can get a Route 44 for just a couple of dollars. These are all calories that you take in. And then there's obviously genetic. We know that if we take an adoptive child, their adult BMI will be closer to their genetic parents' BMI than it will be to their adoptive parents. So obviously there's a genetic component taking place as well. And then a new thing that we've found recently is ghrelin. So ghrelin is a hormone that's found in the gastric fundus. This is when I show you a picture of the stomach, the upper right portion of the stomach. What it does is it stimulates your appetite and tells you you're hungry. So what you can see on this slide is you can see at breakfast, ghrelin is stimulated and it's telling you you're hungry. Then you eat and it goes down. And then it stimulates again at lunch and then goes down. Stimulates again at dinner, goes down, and then stimulates once again at midnight for that midnight snack. What you can see at the bottom is a person who's had a gastric bypass. So this area of the stomach has been bypassed, and you can see that they don't go through these ghrelin swings and these hunger stimulations like somebody who is normal, who has normal anatomy or is just trying to do diet. This is why diets are very, very hard, but this is why bypasses and sleeves, who also have this effect, you don't have this problem in these hunger swing problems. Now, what I do know is you're sitting here and watching this because you have tried 1, 2, 3, or even more of these diets. And the sad fact is you've probably tried them, and after 6 months you did pretty well, but then you kind of lost a little track, and then 6 months later it's a year out and you've gained all that weight back that you lost and 5 pounds more. I know this because there's been a study done that shows if your BMI is 35 and you try to lose weight by dietary means alone, that the chance that you'll keep that weight off and keep your BMI below 35 is estimated at 3% or less. This is a study done by the NIH a number of years ago. So you're not alone in this endeavor. The NIH, based on this research and others, in 1991 made a consensus statement that says for patients who are morbidly obese, meaning BMI greater than 40, that surgical intervention is the only method proven to have a significant long-term impact on the disease. And then the caveat of that with when medical interventions have failed. So with that, we know that diet is very good at losing weight. Behavior modification is very good. Exercise, some medications have worked in the past, and psychological counseling and surgery is very good. Now, the key is not just to do one, two, or three of these, but is to put all of them together. And surgery is one of the very, very effective tools at losing weight, but it is just that, it is a tool. And like any tool, if you don't use it correctly, it will not work correctly for you. So you must use it correctly in combination with all of these other to get the best weight loss. Now, the surgical treatment, right now, there are 4 major operations being done in the United States. The adjustable gastric band, the sleeve gastrectomy, the Roux-en-Y gastric bypass, and the duodenal switch. I'm not going to talk too much today about the duodenal switch because less than 1% of people are having the switch done. If this is something you're interested in, I'd be glad to talk to you about it in the office. Specifically, we'll talk first about the adjustable gastric band, or some people call the lap band, or the Realize band. What this is, it's a little inflatable balloon that goes around the very top part of the stomach. It's attached to this tubing that's attached to a port down here at the bottom. This port sits underneath your skin and allows me to access it over the course of the next many months and years to tighten it as you lose weight. So we make sure you continue to get the restrictive feeling. The way the band works is food comes down your feeding tube of the esophagus into this little pouch that's created by this band. It expands that pouch, and by dilating that pouch, it sends signals back to your brain saying, hey, you're full. You feel full, and then you don't eat anymore. It really restricts how much you take in. Some people like this because they feel that it's reversible. I really like to say it's more removable, but there will be some scar tissue there after it is removed, so it's not 100% reversible. This is a lower operative risk than the other 2 procedures and a shorter hospital stay. Most patients I do this on in the morning and they go home in the afternoon. It's an outpatient procedure. Concerns for this surgery: it's a slower weight loss. It takes about 2 to 3 years to lose all your weight. It's easier to cheat. And what I mean by that, if you take in a lot of liquid calories, they will come in and distend that pouch, but then they will slowly seep into the rest of that stomach, and you'll lose that feeling of distension pretty quickly thereafter. You have to come back in for multiple clinic visits and adjustments much more often than the other procedures. And if you don't like needles, this may not be the one for you, because I have to access that port with a needle in the office. Some people don't like this because it's a foreign object and they just don't want that inside. All of these procedures, all 3 of them, I do laparoscopically, meaning 5 small little incisions, all about 5 millimeters. But I have to make one a lot bigger for this incision to put the port in. Actually, this is the biggest of all the incisions for all 3 of the operations. The big complications that we worry about this procedure is first a slip or slippage, which we know now is about 12% over 5 years. This is concerning because if you have a slip, a lot of times we have to remove the band. Occasionally I can go back in and readjust the band and put some sutures in and try to fix the slip, but a lot of times we have to remove it. Slips are concerning because if you don't take care of a slip, it will lead to an erosion. Now, you will know when you've slipped because everything you eat you will throw back up. But if you keep doing that, it will lead to an erosion, and now you have a hole in your stomach. This happens about 1 to 2% of the time over a 5-year period. Number of people will have pouch or esophageal dilation just because they're overeating. You can have port malfunctions or just tubing malfunction in general. The mortality rate for this is 0.05%, so that's very, very low. It's a very safe operation to perform. Complication rate for all of these procedures is about 15% over 5 years, no matter which procedure it is. It just depends on which complication you would get if you fall into that 15%. Sleeve gastrectomy is the next operation. This has become very, very popular. It's the creation of a very thin sleeve of stomach. This kind of looks like where we take the stomach and create it into what I like to call a garden hose. So your stomach, when I'm done with this procedure, if you can imagine, will look like if you take your large garden hose and you cut it about 1.5 feet long and you look inside, That's how big your stomach will be when we're done with this operation. This also is a purely restrictive procedure, just like the band. It works very similar. Food comes into the stomach, it distends the stomach, and sends signals back to your brain saying, hey, you're full, don't eat anymore, and you're not hungry anymore. This is obviously not a reversible operation. When I finish stapling this off, I excise this whole larger portion of the stomach. So we've removed about 80 to 85% of your stomach when we're done with this procedure. We can't put this back in, so this is a permanent operation. Later, this can convert it to a gastric bypass. Some people have put bands over these as well if you need more weight loss down the road. Um, Finally, the average weight loss for this is 55 to 65% excess body weight. It happens over about 18 to 24 months. So whereas the band was excess body weight of about 45 to 55%, this is 55 to 65%. So a little more and a little faster. And what I mean by excess body weight when I discuss this is the number of pounds you are over your ideal body weight. So if you're supposed to weigh 150 pounds and you weigh 250 pounds, that means you're 100 pounds overweight, or that's 100 pounds of excess body weight. So with this procedure, you would suspect to lose about 60, 65 pounds. People like this operation because there's no foreign body like the band. They like it also because there's no dumping syndrome like the gastric bypass, which I'll talk about in a minute. There's no need for fills or adjustments or needles like the band. It's a simpler operation technically than the gastric bypass, but it's more difficult than the band. So you can see it's kind of the middle operation between these three operations. And for me, I think this is a safer operation and probably the best operation for anybody with a BMI greater than 60. And I can explain that more in the office. The complications that we worry about with the sleeve gastrectomy is first a leak. Leak is where this staple line that has been created, we worry about one of these staples coming out at some point early on. And then obviously gastric fluid and contents leaking out. So how do I protect against leaks? Well, there's a couple of things that I do. First, I reinforce this entire staple line with a biologic device that allows me to staple not just the stomach together, but staple this biologic mesh, if you will, to itself, meaning the staples are stapled to it and just sandwiching the stomach in between. This gives extra strength to the staples. Second, at the time of the operation, I will go down with a scope on the inside of your stomach while I watch laparoscopically on the outside of your stomach. I will put water in through my laparoscope and I will look inside with my scope inside your stomach. I will blow it up with air, and if I don't see any air bubbles come out through the water, then I know we are airtight. So before I ever leave the operating room, I will know that you are airtight. And then, just to make sure you have no leak, the day after, the day of surgery, you will have nothing to eat or drink. The next morning, we will take you down to radiology and we'll have you drink some contrast. And we will watch it go through your stomach and all the way down to the rest of your intestines and ensure there's no leak. Then we will start feeding you. At this point in time, you will start my very strict post-operative diet that I will talk to you more about in the office. But this will be a very strict diet of only liquids for the first 2 weeks, then puree diet for the next 2, and then we'll start you on some soft foods after that. This allows your stomach time to heal, and we do not stress it with any extra foods. Other thing we sometimes worry about with this is stenosis or stricture. This happens about 1 in 50 patients where they have a little stricture or a tightening at some area in the stomach as it's healing. If this happens, it's something we can fix by taking the endoscope back down your stomach and kind of ballooning this area up. Malabsorption of vitamins, we're concerned about all of these, and that's why we ask you to take some vitamins, supplements for the rest of your life. There are vitamin supplements like we offer on our website that are an all-in-one vitamin that we recommend, or there are other vitamins that you will need to take, and we will you will be able to discuss with the dietitian. But you need to take those for the rest of your life because it's important to make sure you do not get vitamin deficient. Finally, gastric reflux is probably the complication we see the most with this operation. And you get reflux because we have created something that was originally big and floppy into something that is now basically a steel pipe. Because of this, it allows when things come into the stomach, especially if you eat too much, you may feel it trying to reflux back up because that pylorus, the muscle that allows it to empty into the rest of the small bowel, is still going to be tight. And a muscle, if you overfill that sleeve, it can reflux back up. As your body adjusts, it adjusts to this over a number of months. And most people who do have a little bit of reflux after surgery have um, have adjusted to it, and their body has figured out that this is their stomach for the rest of their life, and the reflux pretty much goes away after 4 or 6 months. And then there's the Roux-en-Y gastric bypass. The gastric bypass we've actually been doing for the longest. We started doing this operation in the 60s, but we've only been doing it laparoscopically for about the last 15 years or so. This operation is done by creating a small pouch at the top of the stomach that's about the size of a large egg. We then cut the small bowel in the middle and then bring that end up and sew it into the small little pouch and then reanastomose the bowel down further down the bowel. That's why it's called a roux, as the guy invented it. Why? Because it looks like a Y, you can see here. Gastric bypass, because it bypasses the majority of the stomach. So this one is restrictive because you have a small stomach just like the other two, but it's also malabsorptive because food comes in and it doesn't go through part of the stomach or through part of the first part of the intestines. So with this, as expected, you would get even more weight loss, about 65 to 75% of excess body weight loss. And it happens a little quicker. About 18 months you'll lose all your weight. Hospital stay for this operation is about 2 nights in the hospital. It's only 1 night for the sleeve, sometimes 2 for the sleeve. And then, like I said with the band, it's you go home usually same day. So complications for the bypass, once again, leaks we worry about. Most leak rates in the literature are about 1 to 2%. And it's something of concern. Now, how do I prevent leaks? Well, I do all the same things we talked about with the sleeve, with the air check and the check the next day, but also the way I do a bypass is different from some other patients. So I don't just trust staplers on this. I actually staple and then sew and then over sew. So with mine, anastomosis at that site, it's not just stapling, but it is sewing all the way around 2 times. This gives a nice closure, and if something is going to leak, it's going to have to go through 2 layers of closure. Why do I do this? Well, because where I trained at the University of Florida with Kafir bin David and Anhel Kaban, they had done 1,000 of these in a row and had 0 leaks doing it this way. So that's much better than the national average and has made me a believer in this way. What does that mean to you? It means the operation may take a little bit longer, but if we can decrease the leak rates by that much, it's a much safer operation in my opinion. Stricture is sometimes happens. About 1 in 50 people get a stricture, and that's just because when we do so much sewing, we can have some swelling. If we get some swelling, then you get a little swelling right after surgery. Things don't go through as quickly as we would hope, and so we just have to give you an extra day or 2 to let the swelling go down. The mortality rate for this is less than 0.5%. In today's world, it used to be 0.5%, but we know now it's around 0.3%. So very, very low mortality rate, but still not 0. And I'll talk a little bit more about that in a minute. Complication rate, once again, is 15%. Other complications you'll see with this operation are dumping syndrome, which is where if you take in something high in sugar, like a cookie, then you will get dumping syndrome. As I tell my patients, dumping syndrome is a complication, but it's also a good thing. The reason it's a good thing is because It's when you take in something high in sugar, like a cookie, you really shouldn't be. It is not on your diet. And if you take that in, you'll get dumping syndrome, which is a feeling of flushness and fullness and just being miserable. And then after about 30 minutes of feeling like this, you'll run to the bathroom and have a large bowel movement, thus the term dumping syndrome. So I have patients all the time who come back at the 6 month and year mark that tell me, Doc, you were right. That dumping syndrome, it really did happen. And I say, I know it happens. That's why I told you not to do it. And I said, well, will you ever have a cookie again? And they said, no, I'll never do that again. And so it's good. It's good for the diet, but it also can be um, problematic for some patients. Dumping syndrome can happen with various different things. Some people get it with alcohol. Everybody will get it with a candy bar or a cookie. And some people get it with other foods and greasy foods. Internal hernia happens usually 4 to 5 years or more out, and it's where you've lost all your weight, and sometimes your bowel likes to twist around itself. If you get this, you'll come into the ER in pain and throwing up. We'll get a CT scan, and we'll see that you have an internal hernia. We'll take you to the operating room, and we'll fix it. And then ulceration. So ulcerations happen about 10% of the time. This is where at the junction of the stomach and the small bowel, you can get an ulcer because there's some stomach acid there that can cause an ulcer at that junction. 10% of the time is some of the reported literature. We know we can knock that down to less than 2% of the time by simply making sure you don't smoke. So if you're going to be one of my patients, you cannot smoke. You have to quit smoking before I'll ever do the operation. You have to agree that you won't smoke because it's just too dangerous and it adds too many complications and it's too dangerous for your life. We decrease this even more by asking you to be on a proton pump inhibitor for the rest of your life to decrease the acid secretions and decrease ulcers. This will drop it well down even more, to usually less than 1%. So a big misconception some people have is that surgery is very dangerous and it should only be undertaken as a last resort. Well, let's look at some of the facts in the literature. First, remember once again that breast cancer and colon cancer are, that obesity, is killing more people than breast cancer and colon cancer combined. Once again, if your BMI is over 35 or 40, your chances of dying in a single year are significantly higher than somebody who is of normal weight. Here is a study done by the Swedish obesity group. And what they found was they took 2,000 people who went bariatric surgery and 2,000 people who received medical treatment. They followed them for over 10 years. And what they found, according to this chart, you can see is, yes, in the first year, it's a little riskier to have surgery. But after about year 1, year 2, you can see the number of people who had died is much higher in the group who did not have surgery than did have surgery. Here's another study done at McGill University. It compared over 5,000 patients who were managed just with medical management and diet and exercise versus 1,000 patients who underwent surgery. What they found was the 5-year mortality rate in the no surgery group was 6.17%. The 5-year mortality rate in the surgical group was 0.68%. So once again, that number is not zero, but you can see a very significant drop in long-term risk after surgery. So what increases your risk for surgery? Well, a couple of things we know increase your risk. If you have more than 5 medical problems, then you're a little higher risk patient to undergo any surgery. If your BMI is greater than 50, then you're a little higher risk to undergo any sort of surgery. Older people don't heal as well, so they are a little more increased risk. For whatever reason, men are a higher risk category than women. Diabetics, for any surgical procedure, have a higher risk for having surgical complications. And then blood clots. We worry about blood clots right around surgery in any patient who is obese. We'll help prevent blood clots by making sure you get a blood thinner before surgery. We'll put little squeezers on your legs for the entire time you're in the hospital. And the nurses that I work with at all my bariatric centers know that they have to get you up and walking around within 2 hours after surgery. If you're walking, then we'll make sure we can decrease those blood clots and the chances of them giving you problems. And then smokers. We know smokers greatly increase problems after surgery and for surgery. So once again, you need to quit smoking before I consider operating on you. We're going to still take care of the number one killer in America just before we take care of the number two. So this is why I do the operation. It is wonderful to see people lose weight and gain their energy back, but it's also even more satisfying to see people get rid of their medical problems. Here is a patient who had a gastric bypass. These are all the medications he was taking the day before his operation. This is a year later on the right, and these are how many of those medications he had to take a year later after his bypass. Here, this is some research that was done and presented in the Journal of the American Medical Association, and looked at gastric bypasses specifically over many years. And what they found was in diabetes, 70 to 80% of people no longer needed their medication. They had full resolution. 80 to 90% had improvement. Hyperlipidemia or high cholesterol, 65 to 75% resolution, 75 to 95% improvement. Hypertension or high blood pressure, 50 to 75% resolved. And then sleep apnea, 85 to 95% resolved, almost a cure for sleep apnea in most patients. Here's another slide that kind of shows some of the same for all bariatric procedures. And you can see quality of life improvement. 95% of patients said their life was improved after surgery. So weight does stay off with proper diet and exercise. We know this because we have great follow-up data 5, 10, 15 years out. So where do you go from here? Well, from here, after you're viewing this webinar, you can come to our clinic. We would be glad to see you and talk more, and specifically talk what is the best operation for you based on your medical problems and what you want and previous surgical history, and then just in your nutritional status and how you eat now. Every patient is different. There is no one right operation. Every patient is different, and we need to tailor the operation to you. So please come in and visit us. When you come in, please fill out all of the paperwork that you can find on my website, as well as bring documentation of all weight loss attempts. And then the more information you can bring us and the more medical records, the better. We also need a supporting letter from your primary care doctor or another medical doctor. This could be an orthopedic surgeon, a cardiologist, an endocrinologist, anybody who says this is a good idea. And then agreement to comply with therapy, which you'll find in my packet on the website. Agreement to comply with therapy, that you agree to take vitamins and supplements as directed. It's very important. That you'll follow the guidelines of the pre- and post-operative diet. That you agree to exercise on a regular basis. That you will not get pregnant for at least 2 years after surgery. This is very important. We don't want you to be losing weight when you need to be gaining weight when you're pregnant. That you agree to quit smoking and you'll be smoke-free for at least 2 months before surgery, and that you will remain smoke-free for the rest of your life. And that you will agree to follow up with me. It's very important. I want to see you at the 2-week mark, the 3-month mark, 6 months, 12 months, and then I want to see you every year on your anniversary of your surgery. This is important because we want to make sure your vitamins don't get behind, that there's no nutritional issues, and that that we can take care of you. We are here for you for the long term, and we look forward to taking care of you for years ahead. And then another rule for me is you cannot gain weight during the evaluation period. Many insurance companies require an evaluation period of 3 or 6 months, some even up to a year. During this time, while you're meeting with psychologists and nutritionists and medical doctors, you need to be focused on losing weight. If you're gaining weight, that shows me that you have a lack of motivation, and I will consider canceling your surgery until I see a good motivation of really trying to lose. After the clinic, we will order a bunch of laboratory studies to make sure that there's nothing else we can do to help you with weight loss. We also may need cardiac studies or sleep studies, depending on your your actual medical situation. Everybody sees a psychologist for a psychological evaluation who will discuss uh, the process and make sure that you are ready for this major change in your life. And then everybody sees a nutritionist at least once to kind of talk about your dietary habits and how they will change and what you will need to focus on in the future. With that, I want to remind you once again, surgery is a tool. It's a very, very effective tool, and we are here to help you along the way. We hope that you come and visit us, and we look forward to partnering with you on this journey. With that, we would love to answer questions. You can give our office a call, or you can visit our website, which has much of this information on it, or you can review this webinar once again. But please don't hesitate if you're interested to make an appointment, and we'd be glad to see you in the office. Thank you.